So in general, PCT should not be used to decide whether the patient should be initiated on antibiotics. There are several false positive causes for PCT: newborns less than 48 hours, primary inflammation syndrome, non-infective causes of tissue necrosis, burns, trauma, surgery, pancreatitis can all be associated with PCT, prolonged circulatory failure, malaria. It has been shown that certain non-infective, non-bacterial infections, including malaria, PCP, pneumonias, can all be associated with high PCT, associated with a less stronger spike in PCT than typical bacterial infections like, say, strep pneumonia or H. influenza. If the person has already received antibiotics, that can also blunt the PCT response. So how do you clinically integrate? This is from UpToDate. So if the patient has a suspected community-acquired pneumonia, the ideal is to obtain, please remember, serial procalcitonin levels every 1 to 2 days. There is no role for a single value to decide yes or no. If the procalcitonin is declining, if the procalcitonin is stable or rising, look for an alternative cause for PCT elevation in a person who's on antibiotics for community-acquired pneumonia, or consider changing the regimen because the person is probably not responding. If the PCT level is less than 0.5, then if it is yes, discontinue the antibiotics, provided that alternative diagnosis is made out. If the person has a viral pneumonia or there is a clinical improvement in CAP because of antibiotic therapy. If the peak level is less than 5 and the decline is more than 80%, you can stop the antibiotics. But if the level is more than 5, or if the decline is not as much as 80%, then you may need to continue antibiotics. So the role of PCT is more important in antimicrobial stewardship factors to stop the antibiotics than initiating antibiotics. So in clinically stable patients, I repeat, say for example a person with community-acquired pneumonia, a fall in the PCT of more than 80% or drop to less than 0.25 microgram per liter is an indication to stop antibiotics. In critically ill patients, the cutoff is 0.5 or 80% less than the initial PCT value. This is an indication for stopping the antibiotics. It is useful for prognostication, but we don't have a threshold. For patients with ventilator-associated pneumonia, usually a high PCT is seen. So if the PCT is low, if the point goes against VAB, but I repeat, initiating antibiotics, especially in something which has an impact, a strong impact like a ventilator-associated pneumonia, should be based on clinical grounds, not on PCT values. In general, PCT is not elevated in COVID-19. There is a variability where typical pathogens like strep and H. influenza are associated with a more robust response than atypical pathogens like Legionella, and you can also get the positive response in malaria, PCP, and Candida infections. We do not have enough studies in immunocompromised population, patients who have undergone surgery, trauma, who are pregnant, or who have other severe physiological stress to decide what would be the ideal cutoff or how you interpret them. In patients with chronic kidney disease, the PCT is not cleared fast. So in patients with renal insufficiency, please be careful when you interpret PCT values, especially if they are high. Lastly, limitations of biomarkers. We don't have well-defined cutoffs. There are a lot of false positives, false negative reasons. The cost of the test is high. Turnaround time may not be in 1 to 2 hours, which is going to make the difference. The real-time changes are difficult to follow in real world, and extrapolation of evidence to special populations is also lacking. So with that, I am going to briefly describe 4 or 5 scenarios so that we can understand better how to interpret the biomarkers. The first case is a 63-year-old male, a smoker, a hypertensive, and a diabetic, who presented with a sore throat, pain in the throat, rhinorrhea, followed by fever for 4 days. He has a persistent cough. He has a chest pain, mild dyspnea with myalgia. Other family members have a similar illness. The chest is clear on examination, the counts are normal, and this is the X-rays. The CRP is 112. This is a classic influenza-like illness where there are several members of the family who are down with a similar infection with cough, myalgia, pharyngias, rhinorrhea, sore throat. And the high CRP, even though this is a viral infection, is very strongly in favor of influenza or an influenza-like illness. So, if the patient is very unwell in your ICU requiring oxygen, you may still consider antibiotics. What we refer to as severe influenza, but in other situations, a high CRP of 112 should not be a reason for initiating antibiotics if the patient is in the outpatient department or even in the ward and is very, very stable. The second case is a 55-year-old lady, diabetic hypertensive pulmonary artery disease. She is hypothyroid with ischemic cardiomyopathy, presents with breathlessness, a feverish feeling and palpitation for a few days duration, so less than a week's duration of progressive breathlessness and palpitations, and she feels feverish. There is a similar illness in the husband, so that confuses matters. So is she having a viral respiratory illness or is it something else? The counts are normal, the polymononuclear cells are also okay. Procalcitonin is 0.1, creatinine is 0.09. Will you initiate antibiotics in the patient? With a normal PCT, you are not sure whether the person is having a viral infections or heart failure. Now this is the X-ray. There is cardiomegaly, there are features of pulmonary edema. There are probably doubtful shadows which you are not clear whether this could be a bacterial infection. So in this situation, even though the PCT is probably not significant, I think you still would initiate antibiotics till we are sure that this is not a pneumonia which doesn't warrant antibiotics. So this is to illustrate that a normal PCT in a situation where the doubt of a community-acquired pneumonia in a person who has a poor lung reserve or a heart reserve, you may need to start antibiotics, but you can reassess it. So don't look at the value alone to decide whether antibiotics are needed. The third case is a 77-year-old male smoker with coronary artery disease, past history of heart failure. He presents with a progressive breathlessness. He denies fever or chest pain. Features clinically suggest heart failure. There is a third heart sound, that is tachycardia, and the procalcitonin is 0.02. But again, the treating doctor thought that antibiotics were necessary and diuretics were also started. Clinically, after 4 days, there was not much of an improvement, and a repeat PCT after 3 days was again 0.1. Will you escalate antibiotics? The answer is no. This person has come with what appears to be definitely heart failure with a normal PCT, and after 3-4 days there is no elevation of PCT. There is enough evidence to say that this is unlikely to be an infection, and I would look at other reasons why the patient is not responding to treatment. Maybe you need to optimize the heart failure treatment, or need to look at other causes rather than considering infection as a possibility. 2 normal or insignificant PCT values is reasonable to say that sepsis is less likely. 38-year-old smoker, poorly controlled diabetic, admitted to the ICU with fever, cough, and dyspnea for 5 days. This is his X-ray. There is a nice patch here. Started on pomoxiclav and doxycycline. Procalcitonin on admission was 22, which is significant. After 3rd day, he was afebrile. He was moved to the ward. He still complained of mild breathlessness, and a repeat PCT on day 7 was 0.5. How long would you continue antibiotics? Now, the person has come with a very typical community-acquired pneumonia. He's responded, he's become afebrile, he's moved to the ward, and the PCT has dropped from 22 to 0.5, definitely more than an 80% drop in the PCT. And on day 7, if the only symptom is mild breathlessness, I don't think that this is an indication to continue antibiotics. So this is a very clear picture where PCT is useful in antimicrobial stewardship to decide that you can stop the antibiotics beyond 7 days. Antibiotics is not indicated. Maybe he has a poor lung reserve because of being a smoker, he has a COPD, but that has to be evaluated, but antibiotics are not the answer. The last case is a 37-year-old male with no comorbidities. He has myasthenia. He was ventilated in the ICU. On day 9 of ventilation, they were considering tracheostomy when he developed fever. There was a suspected VAP. The chest X-ray, this is a chest X-ray. It was a little, what we would refer to as a dirty X-ray. The count is normal. The procalcitonin is normal. Would you start antibiotics? This also we discussed earlier in a situation where there is a possibility of ventilator-associated pneumonia, which has a significant impact on outcomes. A normal PCT or an insignificant PCT does not rule out an infection totally. So I would suggest, if clinically VAP is suspected, you need to start antibiotics. Maybe follow him up more closely to see whether you can stop them early or look for other reasons, for these infiltrates, rather than wait and watch. This PCT with being normal is not a clear marker saying that there is no infection. So lastly, we are in an age where, as we look forward, this is how things are moving. The patient's attenders are telling the doctor the PCT is elevated. So why are you not escalating antibiotics? I've checked with ChatGPT that when the PCT is elevated, antibiotics have to be escalated. And probably this is what we'll be left saying. This is a self-help hospital. You diagnose and treat yourself. We only offer high-speed Wi-Fi. So in an area where AI is slowly taking over most of doctors' analysis and algorithms, I don't know how long we are going to still lead and have the patient's confidence. But definitely, I think experience and analysis of several years and decades is definitely better in integrating these with clinical medicine than what machines can gain. How much ever you may say about large language models, I still feel that doctors have a role to play. Thank you.
Thank you, Dr. Yash, for a wonderful talk. Thanks for explaining the utility of CRP, PCT in the ICU practice and the pulmonary practice. You highlighted the kinetics, the clinical pathway, and most importantly, the judicious use of these biomarkers in our practice. You told us when to use these biomarkers, when not to use, and the cases you discussed at the end were probably more inclusive about the lessons and topics. Thank you, Dr. Yash. We move on to the next talk. The next talk is by Dr. Desai. Dr. Desai has been already introduced by Dr. Chawla sir. Dr. Desai will be talking about antibiotic classes in ICU and pulmonary practice. You all understand antibiotics have the most important role in treating life-threatening infections, both in pulmonary practice as well in ICU practice. Dr. Desai will throw light on his views about antibiotic classes in respiratory and ICU practice. He will tell us about the predicament under treatment versus over treatment, and the art of antibiotic use is not about using the strongest drug, but using the right drug and using it smartly. Over to you, Dr. Desai. Thank you.
Just a second, I just wanted to tell Ram that we'll have question answer session in the end. So stay back. Thank you.
And I apologize, I didn't call you Aakanksha, sorry. I got very confused, apologies.
Please post your questions in the chat box, all the attendees. Please post the questions in the chat box. Thank you. Over to you.
Good evening. Thank you, Dr. Rajesh Chawla sir, for inviting me to speak at this platform. And thank you, Dr. VRS sir, for that excellent and very informative lecture. So today I have been asked to speak on the topic of antibiotic classes in respiratory and ICU practice. So naturally, the way one would talk about this in a lecture would be cover one class after the other, slide by slide, mechanism, dose, spectrum, side effects, etc. But Dr. Chawla told me specifically not to do that because that would get very boring, and that we should take a case-based approach, right? So what I have decided to do is, over the next half an hour, we'll embark on a kind of a thought experiment, right? We'll examine one case of a pneumonia from the community in the ICU, and we'll examine a second case of a patient who's in the ICU and has developed an nosocomial pneumonia, and we will try and see what our empirical choice of antibiotics should be in this situation. And there has to be some logic to our choice of antibiotics. Not everything can be meropenem and picoplamin. And in the process, we'll end up discussing aspects of the various classes of antibiotics that we have, and we'll try and keep it clinically relevant. So in the ICU, you have a patient, and that patient has an infection. We've established this patient has an infection, and you need to start some antibiotics. So what is your logical approach to this scenario, right? So the first, you will basically be asking yourself a series of questions, right? The first question will be, what is the source of the infection, right? Is it respiratory, or is it a urinary tract source, or is it intra-abdominal or skin and soft tissue? Then the second question you will ask yourself is this infection acquired from the community, or is it a nosocomial infection? And in about 80% of cases, this distinction can be made with a reasonable degree of confidence based on the history alone. For the remaining 20%, that margin is a little blurred, and your choice of antibiotics have to be made on a case-by-case basis. So on the basis of your answers to the first and second question, you will decide what spectrum of organisms do you want to cover with the antibiotics that you will be starting empirically, right? And then you will look at your own local antibiogram, in the sense what is unique to your particular setting. Are there some organisms which are more common than others? Or is there some particular pattern of antibiotic resistance which is unique to your setting, which would affect your choice of what antibiotics to give? And then you'll ask yourself, how sick is the patient? Is the patient, if there is shock, organ failure, etc., then you don't have much room for escalation, in the sense it's do or die at this point. So you will want to make sure that you're covering the full spectrum, and then once the patient improves and you have culture reports, then you can de-escalate. So most likely in the ICU with sick patients, you'll be adopting a de-escalatory approach. Then once you have all this decided, you will choose your antibiotics to cover this spectrum, and you will choose them in such a way that you can achieve the optimum PK/PD at that particular site. And then you will factor in any other aspects that might be unique to that case, which is something you'll decide on a case-by-case basis. So let's look at the first case. We have a 53-year female. She has a history of fever, cough, shortness of breath for 3 days. She is hypoxic. She is requiring mechanical ventilation. She is hypotensive. She is requiring inotropic support, and she has neutrophilic leukocytosis on her CBC. And this is her chest X-ray. You can see a patch on the right side, right lower zone. Right? So this is your garden variety case of a community-acquired pneumonia, right? She has just come from that community. Last night she was admitted. She is reasonably well-controlled diabetic, but no other comorbidities, no previous hospitalizations. She has a influenza-like illness 1 week back, right? So you answered the first question. There is an infection. Where is the source? It is the lung. Is it from the community? Yes, it is. This is pretty obvious, right? So now the next question you'll ask yourself is, what spectrum of organisms am I looking at covering? And this is the way I like to sort of break it up for the purpose of this discussion with regards to antibiotics. Most of you all already know this. You know the typical pathogens. So probably 1 in 2 to 1 in 3 of all pneumonias will be because of strep pneumonia. And it's written in all of our textbooks that strep pneumonia is the most common cause of pneumonia. And for years this has been sort of like a myth, because we very rarely see it grow in culture, right? Even a single dose of an antibiotic won't allow it to grow. It's an organism that is fastidious. But now in the era of PCR, we know that actually what is there in the textbook is the actual reality on the ground, right? So maybe somewhere between 30 to 50% of all cases will be strep pneumonia. The second most common cause will likely be H. influenza. Right? Moraxella catarrhalis, this is something that you see in the second community of someone with an acute exacerbation of COPD. Then we come to the atypical causes. And we call them atypical one because they don't have the usual sort of cell wall that we know the other bacteria to have, right? So this affects our choice of antibiotics. We also call them atypical because the patient suffers from what is known as a warm pneumonia, in the sense patchy bronchopneumonia, the patient is doing perfectly fine. But now in the era of PCR, we know that this is not true. Patients with pathogens that previously we thought were atypical can actually come with severe lobar pneumonia, with septic shock, with an empyema, with ARDS, etc. So that the distinction between a typical and an atypical pneumonia is getting more and more blurred. And probably the third most common cause of pneumonia in most parts of the world would be mycoplasma. So it is something that is grossly underdiagnosed because one can't culture it, but it is something that we always want to target when we are treating a patient like this. Right? The others are much less likely to be seen. And then the other 4 bacteria have grouped in in the third category, which is other, because so now, what antibiotics should we start for this patient, right? Penicillin, amoxiclav, ceftriaxone, meropenem. Should it be a beta-lactam? Should it be a macrolide or doxycycline? Or should it be a quinolone? Or do we want to give vancomycin because the patient is sick, right? So not everything is mirror to there has to be some logic to this. So let's go back to our list of organisms, right?
वो कंटिन्यू
In the first category,
कारा मसाला
considering that 1/3 to 1/2 of all of your pneumonia is a cause of strep pneumo, you will want to make sure that you're most definitely giving an antibiotic which will cover that. Right? Of all the antibiotic classes, probably the most desirable that we would like to give in most situations is a beta-lactam, right? Highly cidal antibiotics, very reliable head-to-head with other classes in most settings. They do have much better outcomes. So, how do beta-lactams work? So, we all know that peptidoglycan layer of the bacterial cell wall is important to maintain the integrity of the cell. And the last step in the synthesis of this peptidoglycan layer is the cross-linking of the peptidoglycans. This is done by a bacterial enzyme called transpeptidase. All beta-lactams target this transpeptidase, and in common parlance, we refer to these transpeptidase enzymes as penicillin-binding proteins, like PBP. So, we need to use a beta-lactam that is going to cover strep pneumonia. Now, what the data shows worldwide is that probably 2/3 of all strep pneumonia, which cause pneumonia, will have MICs to penicillin G, which would be considered susceptible. The other 1/3 will have MICs which are higher than what is considered sensitive, but there is no evidence to show that using penicillin in these isolates results in a treatment failure. Right? So, if you were to use penicillin G, or you were to use a variant of penicillin such as amoxicillin or ampicillin, you are likely going to cover most strep pneumonia, right? If not all. So, and if you were to choose some other beta-lactam that has a broader spectrum, right? Like cephalosporin or carbapenem, yes, that will also cover strep pneumonia, but will also be giving a lot of normal flora, right? So we have all our choices of beta-lactams to cover strep pneumonia. Then coming to H. influenzae, many H. influenzae are sensitive to penicillin G, but some H. influenzae produce beta-lactamases, right? The most common beta-lactamases that they produce is the TEM enzyme, which is TEM, which is a broad-spectrum beta-lactamase. So TEM can confer resistance to penicillins, other versions of penicillins like ampicillin, amoxicillin, piperacillin. They can also confer resistance to first and second generation cephalosporins, right? So to cefazolin and cefuroxime. So what are our options over here? We want to cover H. influenzae as well. We are not comfortable giving just penicillin or amoxicillin. So we can add a beta-lactamase inhibitor, right? So we can do amoxiclav. Clavulanic acid will inhibit the TEM enzyme of H. influenzae, and that will allow amoxicillin to kill H. influenzae. Or we can use Pip-Taz, right? So here again the tazobactam will block the TEM enzyme of H. influenzae, and that will allow piperacillin to bind to the PBP of H. influenzae and kill it. The other option is that we go beyond second generation cephalosporins, right? We use a third generation cephalosporin like ceftriaxone. There is no resistance to ceftriaxone in H. influenzae. And practically speaking, coming back to strep pneumonia, more than 95% of strep pneumonia outside the CNS would be considered sensitive to ceftriaxone. And then you have M. catarrhalis, right, which shows no resistance to either amoxiclav or ceftriaxone. So to sum up, if I have to use one antibiotic to cover the entire first column, right, that would either be amoxiclav or ceftriaxone, yeah, with more than a 90 to 95% certainty of it working. Between the two of them, if I had to choose one, which one would I choose? So you have some strains of H. influenzae which show resistance to amoxiclav because of mechanisms other than beta-lactamase production. So there, to a very small degree, ceftriaxone probably has a slight advantage over amoxiclav. We are used to giving ceftriaxone at a dose of something like 1 gram BD for most situations, and if it is meningitis, maybe we give 2 gram BD. But if you look at your textbooks, they will say doses like 2 gram OD. And actually, this is totally fine, because at a dose of 2 gram OD, you will be achieving levels far above the MIC of these 3 pathogens for most of the day. There is no need for it to be a BD dose, right? And there is no need for you to go beyond 2 grams per day, to 4 grams per day for any situation, except for maybe meningitis, right? There is limited penetration into the CSF. So probably, in our setting, our practice will be injection ceftriaxone 2 gram OD, right? So beta-lactam, it will cover all 3 of these, right? Now I also want to cover atypical pathogens, right? So what options do I have for atypical pathogens? Traditionally, that option would have been a macrolide, right? So azithromycin. Macrolides work not by acting at the cell wall level, but they act at the level of the ribosome. So they block the synthesis of proteins. And the most common empirical choice of antibiotics for a CAP would be something like amoxiclav plus azithromycin or ceftriaxone plus azithromycin. In fact, if you see your textbooks for a choice of empirical antibiotics for treating a CAP, they will say things like 3 days of just azithromycin or 3 days of just clarithromycin. And maybe in a different universe, maybe in the West, maybe in the past, this would have worked. Once upon a time, all the 3 organisms in the leftmost column would have been sensitive to macrolides, but now that is not the case. There is widespread resistance to macrolides amongst all of your typical organisms. And now this problem is slowly starting to permeate into your atypical organisms also, right? So sometime after the COVID-19 pandemic, there were several cases of Mycoplasma pneumonia, right, which was occurring in outbreaks, that just refused to respond to macrolides. And this was probably in December of 22 onwards. It started from China, and then
आपका फोन नंबर में फोन में भेजेगा उसको. अच्छा ऐसा क्या नहीं है इधर. 97
child is diagnosed with Mycoplasma pneumonia, receiving azithromycin, but they're just not improving. The hypoxia persists and the child is still sick. And so it turns out that there is a clinically significant degree of macrolide resistance in pneumonia. And there's no way for us to really test for it.
वो मैं WhatsApp में भेजेगा.
In the sense, it's not like these organisms.
तभी तो मेडिसिन का मिलेगा तो आपको
all the AST methods that we saw previously.
वो मैं WhatsApp में भेजेगा.
हाँ ठीक है.
ये मेरा मेडिसिन.
So in this situation, what are our options? So one option is we can go for tetracyclines such as doxycycline. And lots of ID physicians have now made this their drug of choice for atypical cover when you're dealing with a patient of CAP. So bear in mind, Mycoplasma is likely 1/3 of all of your CAPs, up to 20 to 30%. So it is important that this be included, right? So tablet doxycycline 100 mg twice a day, for 5 days or longer, depending on how sick the patient is. Bear in mind that azithromycin and doxycycline have excellent oral bioavailability. One does not really have to give them IV, except of course if the patient is in shock, for instance, where you have questionable oral absorption, and there perhaps you want to give it IV. And doxycycline will also reliably cover all of the other atypical pathogens that you see on the list, except for maybe 1 or 2 species of Legionella that are by themselves extremely rare to encounter, right? So ceftriaxone doxycycline is your standard empirical approach that will cover probably more than 80% of your community acquired pneumonias. Yeah. If you're looking at any other antibiotic options for atypical cover, there is also quinolones, right? Later quinolones that have gram-positive cover, like levofloxacin or moxifloxacin. And these are excellent antibiotics that cover all of your atypical pathogens very reliably and still retain good sensitivity to your 3 typical pathogens on the column on the left, right? But there are several reasons that we prefer to not use them in India, even though they are mentioned amongst the drug of choice for a CAP in textbooks. The most common reason obviously being tuberculosis. So someone has a latent tuberculosis and we're giving them ATT monotherapy while we're treating the pneumonia, then you're increasing the percentage of TB cases in the country which would have resistance to quinolones. And this is a very crucial drug in the treatment of TB which is INH monoresistant or MDR, so we would like to spare that. One notable side effect of both macrolides and fluoroquinolones are that they prolong the QT interval on the ECG. And this is a side effect which sometimes we discount, in the sense we don't appreciate how serious that is, especially in patients who are elderly, who have other issues like hypocalcemia or a low magnesium level, where, you know, if the QT interval goes past 450, past 500, they can have a sudden polymorphic ventricular tachycardia and have a cardiac arrest. And it's something that is highlighted in textbooks, but it's something that we don't take very seriously. So these are also two reasons why we try not to use these antibiotics in patients who are elderly. Yeah. So just to summarize so far, we've tackled the first and the second column, right? The first column, amoxiclav or ceftriaxone. The second column, doxycycline. Yeah. Having said that, there is a newer macrolide now by the name of nafithromycin. Yeah. So resistance to macrolides such as azithromycin and all the previous ones is mediated either through a target site mutation at the level of the ribosome or because of efflux pumps that take the macrolide and throw it out of the cell. So nafithromycin overcomes all of these mechanisms of resistance, and it can be given both orally and IV at a dose of 800 mg per day for 3 days. It's just a 3-day course because it has a long post-antibiotic effect, and because it overcomes all of the pre-existing mechanisms of resistance to macrolides, it can be used to treat pneumonias from the first and the second column. And because it is available in the oral form, it can be used to treat pneumonias on an OPD basis. It will also work for strep pneumonia, H. influenzae, moraxella catarrhalis, when maybe azithromycin or erythromycin might not. But now we come to the bugs in the third column, and the reason I placed them in the third column is if they are part of the spectrum that you are looking at covering, then you need some additional antibiotic coverage, yeah? Starting with Staphylococcus aureus. So Staph aureus in general constitutes maybe 5% of all pneumonias. Yeah? Not a very large number, but when it is the cause, it tends to be very, very severe, especially if it is from the community. In the Indian setting, about 50% or more of all Staph aureus from the community will be methicillin-resistant Staph aureus, which means that all beta-lactams, except for maybe 5th generation cephalosporins, such as ceftaroline or ceftobiprole, cannot bind to the PPP, right? Because it's a different PPP that Staph aureus has. And you know, in this situation, if your patient is sick, if there are cavities, if there is abscess, necrotizing pneumonia, extensive involvement of one or both lungs, the patient is in shock, there is organ failure, then you don't want to miss Staph aureus by just giving, or rather you don't want to miss MRSA by just giving ceftriaxone and doxy or ceftriaxone nafithromycin. So in that setting, what are our options? Right? Now, in the case that we're looking at, this lady is sick with organ failure, ventilator in the ICU, right? So traditionally the option would have been vancomycin, which is a glycopeptide, right? And the way it works is it acts as an analog of, you know, the D-alanine, the last two components of the peptidoglycan. They won't allow it to cross-link. And vancomycin would have been the traditional option for treating Staph aureus pneumonia, which is MRSA. But then there are problems with vancomycin, right? So one is, of course, most people forget to give a loading dose. The normal dose of vanco will be 15 mg per kg BD, so something like 1 gram twice a day. But 20 to 25 mg per kg loading dose has to be given. Most people skip that. Once upon a time, earlier preparations of vancomycin caused ototoxicity. That is no longer the case, but current preparations of vancomycin can still cause nephrotoxicity, right? That is the second issue. The third issue is that vancomycin can cause histamine release from mast cells, independent of any Ig-mediated mechanism. So, if the loading dose or the first dose is given too fast, then the patient can turn completely red, right? Red man syndrome, and this is often mistaken for an allergy, which is not the case. You can always try it again, but then give it slowly. This is the third issue with vancomycin. And the fourth issue is that, ideally speaking, vancomycin requires some form of therapeutic drug monitoring, which is not routinely done in most tertiary care hospitals in India. It's not done in mine. So it has a very narrow therapeutic index, right? So if the levels are slightly below your target, then the chance of treatment failure is high. especially if there is a Staph aureus bacteria. And then if the levels are higher than the cutoff, which is not much higher than the lower limit, then you have a much higher chance of toxicity. So ideally speaking, you need a team of trained clinical pharmacists who will do TDM for vancomycin. And previously that would have been trough levels, but now the gold standard is taking more than one sample and doing AUC by MIC. So it's all very, very complicated to use vancomycin. We are not, most hospitals in India, including mine, are not equipped to correctly give vancomycin for Staph aureus pneumonia, especially if there's bacteria. The same would apply for teicoplanin. It is also a glycopeptide, but our information regarding dosing and TDM is even less than vancomycin. So, we use it comfortably thinking that we're covering MRSA, but probably, we are not achieving optimum outcomes when we give teicoplanin. So, what other options do we have? So, then we have the option of linezolid. And the way linezolid works is similar to macrolides. It works at the level of the protein synthesis, at the level of the ribosome. Dose is 600 mg twice a day. It has 100% oral bioavailability, especially if the patient is not in shock. So it scores above vanco and tico, which are basically completely IV, right? And it achieves excellent concentrations in the lung, in the epithelial lining fluid. And the thing about Staph aureus from the community is it tends to produce exotoxins, right, such as PVL, penton valentine leukocidin. This is basically a protein, so it's being produced in the ribosome. And it is what is responsible for the necrosis that you see in an MRSA pneumonia, or the organ failure and the shock that is out of proportion to the lung picture. So when you're using a glycopeptide, you are acting at the level of the cell wall, but you're not doing anything about the protein synthesis. But if you were to use something like linezolid, then not only are you killing the bacteria, you are also decreasing exotoxin production. And there is trial evidence to suggest that the outcomes, there was a big trial that was published in 2012, where several hundred patients with pneumonia proven to be MRSA, although this was in the nosocomial setting. One group was randomized to receive vanco with trough level monitoring. The other group received linezolid, and overall the outcomes were sort of numerically better in the linezolid group with much fewer adverse reactions. Adverse reactions due to linezolid will include myelosuppression. So it's common to have thrombocytopenia after a certain number of days. Generally speaking, your normal duration for a pneumonia 5 to 7 days, rarely a little longer than that, is not long enough for it to cause thrombocytopenia. So in this setting, that is not an issue. It can cause peripheral neuropathy, but that is after weeks of administration. So we see that when we're treating NDRP. It can also cause lactic acidosis by affecting mitochondrial function in the liver. So all of a sudden, your patient will start breathing very, very fast, but not because they're hypoxic, rather because they've developed high anion gap metabolic acidosis with high lactates, and they're just breathing fast to sort of wash out CO2. But generally speaking, these are not side effects which one encounters with short-term use. So in my setting, if you have a patient who comes with a pneumonia, it will be ceftriaxone doxil. The patient is sick in the ICU and shock, we would prefer ceftriaxone doxil plus linezolid. Right? This is how we have made our protocol. Are there other options for the treatment of Staph aureus pneumonia, or rather for pneumonia where you are also concerned that there is Staph aureus? So, like we mentioned earlier, there are 5th generation cephalosporins. So, all penicillins, 1st to 4th generation cephalosporins, carbapenems cannot bind to PDP2A, which is the kind of PDP you see in MRSA. But ceftaroline and ceftibipirole can. And India now has some experience with the use of ceftaroline. The regular dose is 600 mg twice a day. In severe Staph aureus infections, you can step it up to 600 mg thrice a day. The only issue is that there is no trial evidence as such, comparing ceftaroline specifically for Staph aureus pneumonia versus a standard of care like vanco or anything else. There is observational data, but this observational data is again for pneumonia as a whole, not just for Staph aureus pneumonia. But yes, in theory, if you are concerned there is Staph aureus is the cause of pneumonia, instead of ceftriaxone doxy, We have seen people give ceftaroline doxy, and we've not had any issues with that at all, right? So, so if your patient is sick, then you want to give antibiotics that will cover MRSA, right? So this is the first organism in the list on the right, which requires us to deviate from a normal protocol. The second is hypervirulent Klebsiella, right? So we are used to seeing Klebsiella pneumoniae in the nosocomial setting. We are used to seeing it in the community setting, causing UTIs, causing intra-abdominal infections. But it can also cause pneumonias, and the Kleb that causes pneumonias is very different from the Kleb that we see in all other locations, right? It is very virulent. In the sense, if you have a patient who's come to you from the community with a necrotizing pneumonia, the two differential diagnoses will be MRSA from the community and hypervirulent Klebsiella. And the prevalence of hypervirulent Klebsiella in pneumonia varies from one part of the world to the other. So, for example, in Taiwan, that number could be up to 20% of all pneumonias. I don't know what the data is in India, but it is overall very rare. We have not encountered maybe one case a year. Why are we concerned? Because if it is a Klebsiella pneumonia, then that raises the possibility of beta-lactamases. So most hypervirulent Klebsiella generally tend to be sensitive to most beta-lactams, including ceftriaxone, which means they usually don't have resistance that go beyond broad-spectrum beta-lactamases like TEM in the case of H influenza. But there is no reason why now or in the future they can acquire plasmids which allow them to produce extended spectrum beta-lactamases like CTXN, which would mean that now third and fourth generation cephalosporins are also resistant. So when there is a Kleb, you are concerned that maybe ceftriaxone may not work unless you have that on culture, right? So perhaps this is one setting where meropenem actually has an advantage over ceftriaxone for the first time in this entire discussion, right? Up until now, there's been no advantage to anything broader in terms of your choice of beta-lactam than ceftriaxone. But when it comes to Klebsiella, because of the possibility of ESBL production, yes, maybe if you have a patient with necrotizing pneumonia, one is you'll have Linid, and maybe you will want to, instead of using ceftriaxone, use meropenem. And again, that depends on your geographical setting. And then you have Pseudomonas aeruginosa. Now, Pseudomonas by and large does not cause pneumonia in patients with structurally normal lungs, right? Perfectly healthy person with normal comorbidities off the street coming with pneumonia, with no COPD, no bronchiectasis, no post-TB lung. We really don't need to give empirical pseudomonal cover. But if the patient has pre-existing structural lung disease, ILD, bronchiectasis, etc., then you will want to make sure that your beta-lactam also has coverage for Pseudomonas aeruginosa, right? So there, rather than ceftriaxone, you would want to give maybe piperacillin, tazobactam, or a carbapenem, right? So this is a decision we'll make when the patient has a pre-existing structural lung disease. So here again, there is a second indication where maybe meropenem would give you a therapeutic advantage over ceftriaxone, right? This is only the second time in the discussion so far that this is the situation. And now more and more in some parts of India, we are seeing patients who have melioidosis, right? Which is a gram-negative bacterial infection due to Burkholderia pseudomycin. The organism lives in the soil, it rains, or there's dust, or there's wind, the dust kicks it up, it is inhaled. And patients who are alcoholic or who have uncontrolled diabetes tend to be particularly susceptible. And while it can present with abscesses in multiple organs or chronic suppurative kind of a disease, it can also present like an acute bacterial pneumonia, indistinguishable from any of the other pneumonias, and with sepsis and shock. And where I did my MBBS in KMC Manipal up until 2015, when I finished my internship, we had never heard of melioidosis. It was just a small chapter in the textbook. And now, if you look at KMC Manipal, they have one of the highest incidence of melioidosis in the country, to the point where it's kind of become a center of excellence. So it makes me wonder, is it that melioid is emerging and it has spread over there now? Has it always been over there and we just never had the diagnostics to know? So God knows how many patients would have come and died and we would have not known. So the only way to diagnose this is through culture, and the importance of knowing that it is Burkholderia pseudomycin is because it affects your choice of antibiotics, right? Your empirical antibiotic will be a beta-lactam, and it can be either ceftazidime or meropenem, right? It can't really be anything else. So SITSCon 2 years ago, there was a speaker from Singapore who was talking about how they treat pneumonia in their country. And for them, their empirical choice of antibiotics is amoxiclav plus azithromycin, which makes sense that covers the first two columns, and ceftazidime, right? So amoxiclav, azithromycin and ceftazidime. Now it sounds a bit weird when you look at it, that there are two beta-lactams going simultaneously. But the reason they do this is because myeloid causes up to 20% of all of the pneumonias. In that part of the world, Southeast Asia, Northern Australia, myeloid is a significant chunk of all pneumonias. So they have to give ceftazidime to cover it. But ceftazidime has this unique property, unlike other third generation cephalosporins, where it just doesn't cover gram-positive cocci. Yeah, so if you were to use only ceftazidime and azithromycin, ceftazidime is not going to cover Streptococcus pneumoniae, which is your most important pathogen overall, right? 1 in 3 to 1 in 2 cases. So this is how they have arrived at their protocol based on their local antibiogram. It seems completely gibberish in our setting, but then you can see the logic as to why they would do that, right? So all in all, to conclude this thought experiment, most cases of pneumonia, ceftriaxone doxy, or just nafithromycin perhaps. Patient is sick, you're concerned staph aureus, linezolid. That has the therapeutic advantage. Necrotizing pneumonia, you're also concerned about hypervirulent Klebsiella. No one will fault you for changing ceftriaxone to meropenem. And if you live in a setting which is endemic for melioidosis, or it is the season, or for example in Pune, where we would be concerned about it, we have patients who go back to their village during the monsoons for various festivals. The village would be in Konkan, and then they will come back, and maybe they are diabetic and alcoholic, and they've come back with a bad pneumonia. We would want to cover melioid because more and more local data are showing that this is the epidemiological situation where we would encounter it. We don't have melioid locally in Pune, as of now. And if there is structural lung disease, then an antidomal antibiotic. So again, their meropenem would score over ceftriaxone. Yeah. So let's look at some pitfalls, right? This patient is admitted. She's a community-acquired pneumonia. We have started her on linezolid plus ceftriaxone plus doxycycline, right? Now everyone is fascinated by the use of the biofire panels. Let's say the patient gave a sputum sample before she was intubated, and she's not really producing sputum. This sputum sample has been given in the first 48 hours, and she's mostly given saliva, which is what normally happens, when we ask them to give a sputum sample when they can't produce it. And the panel shows Acinetobacter species, right? So immediately the treating team changes the antibiotics to colistin, right? Now what is the problem over here? Now here your knowledge of microbiology tells you that there is no reason for Acinetobacter to cause pneumonia from the community, right? In all probability, the patient has been colonized orally in the first 24 to 48 hours of her stay in the hospital. So what happens when you change to a polymyxin and abandon all of these previous antibiotics? You are giving an antibiotic that is in itself inferior to all other classes of antibiotics which are sensitive when you consider head-to-head. Number one, an antibiotic that is very toxic, and an antibiotic that has no gram-positive cover. So, we see this happen sometimes where people take the results of the biofire literally rather than applying it to the particular setting in which the patient is in, right? So this is one example of a common pitfall we see. Let's say the sputum biofire, again sent in the first 24 to 48 hours, is showing Klebsiella pneumoniae, and the NDM gene is present, right? So we all know in this situation we will give ceftazidime, avibactam plus astrunan, and we think that no worries, by giving higher antibiotics, it will cover everything else. We'll continue azithromycin or doxycycline for atypical cover, but we also want to cover this Klebsiella. But now again, that is a problem. NDM Klebsiella is not going to cause a pneumonia from the community, where it's clear cut that this patient has no hospitalization before. And again, ceftazidime plus avibactam. Ceftazidime has no gram-positive cover. So again, you are missing out all of a Streptococcus pneumonia by making this change. And this is, again, one situation that we see happen very commonly since the use of biofire has become more widespread. Let's say an ET aspirate is done. It is cultured. It has indeed grown MRSA. Yeah, very good. So we have a staph aureus pneumonia. The patient has thrombocytopenia from before, probably because of sepsis. So the team is not keen to add linezolid. The patient has AKI, so nobody is keen to use vancomycin. So they decide to start daptomycin, which is also an excellent drug to cover MRSA. Yeah. Daptomycin is a lipopeptide. It acts at the level of the cell membrane, and it basically destabilizes the membrane potential, and it's very highly cidal. Only problem is you cannot use it for airway infections, which means if the infection has entered through the airway, reached the alveoli and formed pus, the surfactant in the alveoli will hydrolyze the antibiotic. So using daptomycin to treat a pneumonia is a strict no-no. However, let's say the patient has a lung infection, not because it has been acquired from the airway, but because of septic pulmonary emboli. So let's say the patient has, diabetic foot with an abscess over there because of MRSA and discontinued. Lots of people have this instance. They feel that by changing from teicoplanin to cefazolin, or by changing from teicoplanin to an anisole, from teicoplanin to an anisole, includes the taxon, that includes say, and one that's narrow spectrum. It is going to be by definition a meropenem resistant bacteria. Let's say the ET aspirate culture actually grew Streptococcus pneumoniae, which happens once. They are playing the long game and thinking of the ultimate. There's no justification for continuing meropenem. Or let's say again, ET aspirate biofire has shown microbiology pneumonia. It is perfectly compatible. It is a lower respiratory sample. We don't need to continue the beta-lactam. We escalate to oxycycline. To de-escalation. If you send the report, especially is compatible, maybe she's aspirated. Maybe the primary team has started this empirically because it is the standard choice of antibiotics. Since the patient is choice of antibiotics, since the patient has had a stroke, the patient has developed what we were discussing previously, right? So now in this situation, we are looking at a completely different spectrum of organisms. So therefore, the choice of empiric can apply to us because most of the patients are already on carbapenems for XYZ reason, which might be correct or might be wrong, right? Which might be correct or might be wrong, right? The setting looks like in my hospital. Is most likely good. Antibiotic there is no all like acetylcholine pseudo. But one antibiotic is mixin B. Yeah. With very static is mixin B. Yeah. With very few exceptions, poly B will and genuinely they are antibiotics. But in this setting, at least in my hospital, polymyxin B is one antibiotic. One aspects be one antibiotic, one aspects bundle. Right, and the backbone of it is of 205 times tetracycline is sensitive, and you have no other options in the patient is sick. Maybe you add tetracycline, but you should know that tetracycline is not traditionally considered an antibiotic of choice for add-on therapy to polymyxin. Once you know it is Acinetobacter bombing and you have other options, which is often what the situation is. And to try and overcome the poor PKPD of tetracycline, often people will use a higher dose, 200 mg loading. The main side effect being liver toxicity. And then, if you see the IDIC guidelines, there is very high acid. But in the case of Acinetobacter baumannii, it will act as a beta-lactam, right? It will bind to with ampicillin or when you combine it with ceftriaxone, right? You are looking at 6 to 9 to 12 grams a day of sulbactam, right? The only problem is that we are not actually able to test susceptibility to sulbactam in our setting. Yeah. If it is Klebsiella pneumonia, then the mechanism of carbapenem resistance in Klebsiella is very predictable. It will either be producing NDM or OXA48 or both. Or in the rest of the mavibacterium producing Klebsiella, which does not producing Klebsiella, which does not. In this, if you have a patient who has the VAP, patient has been on carbapenem before and you want to start empirical antibiotics. If you were to start cephazidime, avibactam plus aspirin empirically, remember that you're covering 25-30% of your Acinetobacter cases, right? So that's automatically quarter to a third of the patients who are to die because appropriate antibiotics would have been delayed by 24 to 48 hours. Overall, cephazidime, avibactam, aspirin is a bad choice for empirical therapy. Now, this is maybe unique to us. I think maybe this is something that you'll see in your hospital polyp. We got the culture, maybe it's Acinetobacter, we treated the patient here, they've recovered. Their ICU stay is prolonged. A week later, again you get a call. The patient is again developing shock. Observed at this point is that it is going to be a gram-negative factor. I mean, these organisms would vary from location to location. You know, the weird gram-negative non-fermenters. That remains to be seen by on. And then in the last column, I've put Staph aureus. So Staph aureus is a notorious cause of harm, but not in that setting. It is the most common cause in Western countries. For reasons we are completely in Staph aureus, there is GNB over here. So maybe over there, they would have administered it empirically, but here we don't have Staph aureus cover up front. Maybe once a year, twice a year, with staph growing. And at that point, our foundation has taken the how did staph come in the hospital. But yeah. For the sake of discussion, we should know about staph aureus. Yeah. Okay, pitfalls. Empirical use of cephazidime, avibactam plus aspirin. You already discussed this. You won't cover Acinetobacter, you will cover a large chunk of Pseudomonas. Use of colistin instead of poly. Now, colistin and poly are both bad antibiotics. Colistin is when we first encountered carbapenem. And we are not comfortable with polymyxin people. Any side outside of the urine, you would prefer poly rather than colistin. Let's say the ED aspirin has gone ahead and added fluconazole. One more pitfall. Candida usually does not cause pneumonia. Almost never causes a pneumonia. With thrush in the air, pharynx, etc. And yes, as part of disseminated anemia, the same candida which is growing in blood, can then show. This is a rare scenario, right? If the blood is also not growing and you're not thinking of candidemia, there's no point acting on this information and adding fluconazole. Same goes with a situation like the patient has developed the team has sent a serum, BD count is elevated. You're not really looking at covering candida in this setting, right? There are a number of reasons for a false positive BDG, right? Let's say you have an ET aspirate biofire and it is no Acinetobacter. Makes sense. This is a right. So this is your number of outcomes, but no resistance genes have been found. OXA 23, 24, 51, 58. These are not tested for. So assume that an Acinetobacter is found. Respiratory bacteria. Just remember this algorithm, right? Is there an infection? Where is the source? Is it nosocomial or is it from organisms in general? My friends, the stages of monotherapy, and are there any other relevant factors that are unique to the patient? Yeah. With this, I would like to come to the end of my. I have taken up a lot of time. Any questions? I have to answer.
Thank you, Dr. Desai. Very listed talk.
As if it's the truth and the ultimate truth.
So this will be complementing the traditional microbiology and not replacing it.
Absolutely.
Next question is for Dr. Desai. The question is need for anaerobic blood culture and looking at